Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts and learn how to craft your ideal birth. We will tackle the scary and weird questions that come up along the way and provide answers that are driven by science and evidence-based recommendations. I'm going to show you how to redefine parenthood and choose what's best aligned for you and your goals. With 10 years of experience in family education and a master's degree in human development and family studies, I'm ready to help you navigate pregnancy and explore your birth options to free yourself of fear surrounding childbirth. My goal is to help you have an informed and confident labor experience, plus an empowered and joyous postpartum. Dr. K, welcome to the show.
Thank you for having me. I'm very excited to be here.
I'm excited for today's topic. Now, today's topic is not a joyful one, I don't think, and it is one that is, typically surrounded with fear, but I have no doubt at all that you and I are going to be able to talk about this conversation and empower people. I want people to be educated that A, episiotomies do exist, B, they do have a place in labor, and C, what can you do if you find yourself in a situation that you may need an episiotomy? How do you have that conversation with your provider? And I was sharing with you before we started recording that you are an OB who gets it. So I'm really excited to hear from the perspective of that kind and collaborative provider that we all hope that we have at our labor. I'm really excited to hear it from your perspective. So I think before we get started, can we just maybe define what an episiotomy is and how often you see them being used?
Sure. So, an episiotomy, the intention is a cut in the area near the outer part of our reproductive parts, our vulva. It's in the muscle part called the perineum, which is that space between where the vagina opening ends and where the anal opening begins. So, that in between area of skin underneath it is some level of muscle. And that is kind of this bridge between those two openings. And the intention of an episiotomy is to widen the space, the functional space of the vagina. So it is meant to kind of extend the width of the vagina by cutting into that nearby land bridge between the vulva or the vagina and the anal area. And it used to be used a lot more commonly. From what I can see, it started to come into use around the 1700s by male surgeons, involved in gynecology. At at some point in time, it was thought to be a protective method, maybe to prevent spontaneous lacerations that may be more involved or more complicated, or also to be used if additional space is needed. And I think our conversation will talk more about the current modern role for it, in comparison to maybe a generation or two generations ago, what it was being used for in previous times, and then its current role in modern, childbirth.
And now we don't really see them that often, right? For the most part, people can go in and expect to have their baby and not expect to have an episiotomy, except in pretty rare cases.
So, obstetrics has changed over time. And in the United States, it has, uh, in its genesis, obstetrics, different from midwifery, was pretty much a white male, white collar job, and something that could allow you to become a professional, maybe different than the concept of lords, and serfs and common folk in the British Isles. But it was an opportunity to become a professional, and it was pretty much being done by white men for decades before women in the 20th, 21st century really started getting into the field. And so things have changed over the course of obstetrics in the United States. And there was a period of time where there was a lot of hands-on, and there was a lot of doing things almost like a conveyor belt, like everybody had it done, almost like a prescription. This is what we do in childbirth. And so I think there was a previous generation where there was also a lot of use of forceps. There was a lot of use of twilight, or a medication that kind of made people very sleepy, and their pushing efforts may not have been very effective. and, heavy use of epidurals, which still continues today. And so there was this kind of, I think there was overlap with instrumented help in that part of labor
Mm.
where you're at the stage where you're pushing, but the baby's head hasn't come out. A lot of hands-on and instrumentation in that process. And I know my elder brother, he was a forceps assisted delivery.
Wow.
And my mom was like, she refused to push supposedly. And, she may have, it was her first baby. And she was like, I felt like it was this big turd coming out and I didn't want to push. And so my brother came out with forceps assistance. There was a lot of, okay, we're doing all of this manipulation and we're cutting an episiotomy. And I think it's relevant to say that a forceps is like these big salad bowl spoons, like where you're going to toss this big salad and you have to fit that in the vagina on either side of the baby's head. So you do need more space to get that in. And it depends on that person, how flexible they are in terms of their vagina at that point in time, whether you can fit that in without creating extra room or whether you need to create extra room. So I think there was a generation, from kind of men being involved in obstetrics where there was a lot of hands-on, a lot of doing things, a lot of prescribing. This is what, this is the safest way to do childbirth. It came with a lot of intervention even at that stage of childbirth, like in those last few moments before the baby was born. I think episiotomy was a part of that generation where it was commonly done. It was thought to, okay, well, if we cut, well, we're going to maybe assume that most women are going to tear in a significant way. Well, maybe if we cut it, then it will be easier to repair. These are some concepts that are out there because it will be a defined cut rather than a haphazard cut. And I will say that a defined cut from a surgical repair standpoint can be easier because the lines might be clean. They might be, I don't want to say clean, but they might be straight, simple lines rather than irregular ways that, it's almost like the difference if there's an earthquake, there might be jagged divisions in the ground versus if somebody takes, a saw and cuts a straight line. If you want to fill in that crack, it might be easier to fill in a straight line and really do a solid repair than a haphazard, irregular kind of opening. From the surgeon's perspective, it is easier to repair something that you intentionally cut. You put the layers, you can see them, you pull them together easier. Even maybe a seamstress could appreciate
Mm.
easier to repair something with a defined cut than maybe something that tore in an irregular way. Trying to put it back together in a way that looks aesthetic and that may be functional might be more challenging for that repairing person, the surgeon. Now that might be different than the experience of the healing from the person who's had that opening or had that cut or that laceration, but from the repairer's standpoint, it is easier to fix. And so there's a lot of pessimism sometimes that goes into childbirth or, paternity based maternity care. And there's a lot of, okay, well, this is going to happen. So let me do something to intervene. She's going to tear. It's going to be easier if I just cut it. I'm just going to assume she's going to tear, so I'm going to cut it. And so there was a phase where everybody got an episiotomy, and it was maybe thought to be preventative of something that would have happened spontaneously, assuming that everybody was going to tear in a dramatic way. So that was a previous generation. And as with many things, old concepts don't die out quickly. And and sometimes it's hard to teach new tricks. Not everybody's willing to teach a new trick, depending on how long they've been doing the old trick. And so there's going to be changes in concepts and what maybe newer providers are being taught and what they're willing to embrace, maybe compared to somebody that's been in practice for some time who still feels loyalty to their original ideas or may have some skepticism about some of these newer ideas, or maybe is not really exposing themselves to these new ideas. They're just kind of entrenched in their previous teaching. There was a previous generation where I think that was hand in hand with what we call operative deliveries or forceps, especially forceps. You sometimes will feel like you need more room to apply forceps, and not so much with a vacuum because that doesn't really go in the vagina. It just goes on the head that's crowning. And also with, maybe thinking that this was going to be the lesser of evils. now that we are doing a lot more kind of study of what we've done, looking back in obstetrics, we do a lot more study and a lot more evaluation as much as we can do that safely. And so then the current perspective is, well, this doesn't really seem to be as helpful as people thought it was. Well, it may not be protective. It may not. One, not everybody's going to have a significant laceration on their own. Most people are, I think now we recognize that when we pay attention and we don't do anything, okay, most people are going to have minor openings in the general vaginal vulvar area, things that may or may not even need to be repaired. They might be superficial or very minimal in their degree of lacerations. Now we're looking back at practices and we're seeing, oh, when people have these episiotomies, well, it doesn't prevent pelvic floor dysfunction. It doesn't prevent, prolapse or, loosening of the vagina and the vulva where things feel like they're falling out when you get to your postmenopausal years. And it doesn't necessarily prevent worse lacerations. In fact, in some of the ways that episiotomies are cut may make the likelihood of an even bigger tear after you're cut more common. So those are called like extensions. So when you cut an episiotomy, you cut an intentional cut. But if it rips further, that's an extension, an unintentional elongation of what you did cut. And so what we've seen when we look backwards at past practices is that, oh, well, there's different ways to cut episiotomy, but some of the ways that might be more common in the United States actually had higher rates of going further than they needed to go, or whether or not, that's also a little bit debated because how involved your episiotomy was intentionally has differed over time. So they can be involved with going past just that in between land bridge, what we call the perineum, into the muscle that circles the anus, which helps control holding in gas that we call farts, liquid poop and solid poops. So we need that muscle to know when to
Very
release,
important.
when to release and when to keep it together. We need that. It's called a sphincter. The anal sphincter is that muscle, and it's supposed to have a certain amount of tone. It's supposed to have a certain amount of holding it all in, and then on intentionally letting out different things at certain times. And so because at land bridge the perineum is short, it's very easy to now be in the region of the anus, the muscle of the anus, and to have these cuts become more complicated and to have potentially have lasting impact on that particular birthing person, that woman, and her body and her experience subsequently. In a previous generation, it was not unusual to cut all the way into the muscle of the anus, and that was an intentional cut, right? And then in later generations, it was not. They did intentionally cut all the way through. So there was a generation that they wouldn't have considered it an extension. It was they intentionally cut all the way through, and then they repaired it all the way, and they got very good at repairing all the different layers involved in that cut. But in our most recent generation before this one, we didn't intentionally cut through all of those layers into the muscle surrounding the anus. And so then if the anus muscle got involved, or if it even went through into the anus itself, not just the muscle around it, then we consider that going further than intended. But so there have been some different generations that, how deep the cut was also a generational practice.
Okay, do you think any part of that was kind of experimental? You saying like they learned the different layers. Was there a little piece of this that was like, we kind of need to see what's in there to see how we handle it?
All of medicine is experimental.
Yes, that's true.
Yeah, all of it is study and on the go training, and hindsight is always 2020. We
Yeah.
can always look back after we've done something for a while and say, probably maybe we should stop doing that. but but I think there's a lot different about clinical medicine than like the chemical sciences and the physical sciences. There's a lot, our bodies are not machines,
Mhm.
and there's so much individual nuance. There's a general rubric, but it plays out a little bit differently in individual bodies. And so there's a lot of trial and error. There's a lot of thought that sometimes goes into things, and then you try it out for a season, and then you look back on it and you're like, yeah, we thought that was going to work, but maybe that doesn't seem to be the approach that's getting the desired goal. And so, you know, when people do research, especially if they do research on, like, in a lab, or with even with animal studies where they might have used mice or something, to achieve one small question, to answer one very finite, concrete question, can take years of study, multiple rounds of changing the technique, and then re-examining your experiment to get one very specified question answered. But clinical medicine does not work that way.
Yeah.
Clinical medicine is, in current times, based on all kinds of study, but there's another reality where a lot of it is, um, phases of interventions that then get that are based on concepts. They're based on ideas. They're based on, okay, we tried this in animals. Now we're going to try it in people, or
Mhm.
we've tested that, we've evaluated this concept in study, but then we have to apply it. And during its application phase, it is experimentation. And then you look back on it and you say, okay, how do people do with that? Was it an improvement from what we've been doing, or worse? Okay, well, maybe we should stop doing this if it's worse. If it's better, well, clearly we're onto something. It's not math. Math is a lot, um, it's math is probably more pure
Yeah,
than
it's like
clinical
black and white.
medicine.
It is what it is. The
Yeah.
math will always math, but birth doesn't always work like that. Okay, so before we move on back into the episiotomy realm, I'd like to touch briefly, and I know this could be a whole episode on its own, but on OASIS, so obstetrical.
I think that the last S could even just be injuries, plural, but
Oh,
it could
okay.
also be the syndrome. That's fine.
Got it. I couldn't remember the exact thing. So I know a little bit about Oasis, but walk us through briefly kind of what they are. Does it mean a fourth degree tear? Does it mean a little bit past a fourth degree tear? And then is the answer always surgery? Do you always need surgical things? I only asked this because it sounded like at one point in time throughout the evolution of episiotomies, we were intentionally causing Oasis. And so it made me wonder just about that.
Yeah, yeah. So we were intentionally, I would simplify OASIS as an anal sphincter injury, which essentially means that we've now disrupted or cut completely through or severed through part of the muscle around the anus that helps keep our continence, help us keep our farts and our poops in. And so if it's unintentional, it's a third or fourth degree laceration. But remember, I said earlier, there's a previous generation where they did cut intentionally all the way through. And so they would have been contributing to intentional anal injury, assuming that it was just easy to do it preemptively to prevent spontaneous involvement, and just do a planned demolition and a planned repair. And so there was a generation that cut from the vagina all the way to the anus in a very intentional cut. And so there are a generation of people that have experienced that where it was a routine, planned cut. And from the repair standpoint, it may have been, after a while, it may have been very straightforward how to approach that repair, because you know that all your layers are involved. Then you have a standard approach to put all that back together. Versus when you have an unintentional laceration, sometimes you have to do a lot of evaluation to make sure you can correctly assess what layers have been involved, and to make sure you're not missing layers that are involved that need to be repaired. So generally, once you get down to the muscle surrounding the anal sphincter, whether it's partially disrupted or completely disrupted on the part that's next to the vagina, because it goes around the anus.
Mhm.
So it'd just be what we call the anterior component that's most likely to be disrupted. Because once you get past that first part, then you're in the anus. And then you'd have the underside. Well, we're not going to cut all the way past that. So sometimes when people don't put everything back together, you could get complications like fistula from some areas of unintended openings that were never repaired, and then they could create fistulas, which are essentially these unusual connections between different parts of the body that almost create like a channel, like a straw that is allowing communication between one area and the next. And you don't want communication between the vagina and your anus. Because I mean, they're both bacteria full, but they've got different types of bacteria. And
Mhm.
so one potential link between some of these involvements of lacerations is unrecognized injury that doesn't get repaired, that can then contribute to consequences long term. So they knew there was a generation that was intentionally cutting from the vagina to the anus. And then they knew all those layers were involved. And then they had a systematic approach to then put all those layers back together because they knew they were all involved. Versus if you have an unintentional laceration, you do a lot of evaluation to really start checking, okay, what areas are involved in this. It takes a little bit of time to look at it, really thoroughly examine it, make sure that you have a good sense of where it ends. And then you start to do this repair. And if it's a spontaneous one, it might have non-linear, some curves and jagged edges, and you got to put that back together as best as possible, without overdoing it. So anything that involves the anal sphincter muscle, especially on the side that's closest to the vagina, would be involved in OASIS, or these obstetric-based anal sphincter injuries. And so those can be intentional cuts. They can be extensions from an intentional cut. I think in current times, when people are trying to avoid a sphincter injury, because what we've seen later on when we look back is that, okay, well, maybe it created more space, but then now you have ladies, in their later years complaining that they're leaking poop when they cough or when they laugh. And that's really bothersome, right? That's not something
Yeah.
that people are going to be quiet about. They're going to complain, hey, you cut me, and now when I cough, I poop, and how embarrassing is that? And I have to change myself all the time, and I'm very self-conscious. And when I have sex, maybe I dribble a little bit, and it makes me, it like contributes to all these things that I'm not pleased that you contributed to this. And so when we look back, we see that if the injury, whether it was a spontaneous laceration or an episiotomy, if it involved the anal sphincter, there was an increased potential for later on to have incontinence, fecal incontinence, so essentially you leak poop unintentionally. So then some episiotomy styles have changed to try and avoid that. So in Europe, they do more of a medial lateral, which is, instead of going straight down or, somewhat in the midline, which is what had been done most often in the United States, is a midline or a median episiotomy. You just go straight down from the vagina, you know, down into the perineum, that land bridge in between. Well, maybe the Europeans figured it out earlier than we did, and they started going medial lateral. And so to avoid the sphincter. Now, there's pros and cons to doing that. You're more likely to avoid the sphincter of the anus, so you're less likely to then get into problems with injury to the sphincter and maybe poop incontinence later. But it is bulkier when you go to the side. And so then the downside of that is that the discomfort from that medial lateral could be the consequence of that type of episiotomy, especially in the short term. So when we look back, we can say, oh, well, those episiotomies, well, they didn't get into the sphincter of the anus, but then in the short term, maybe those women had more pain with intercourse for longer. And it still seems to be in the first few months that they may have had pain longer. It doesn't seem to, from some of the information I've seen, it doesn't seem to translate into prolonged past the first few months or into the, past the first year, that people are still complaining of pain. So maybe it's like a short-term trade-off, and that is generally thought to be the preferred episiotomy cut if you think you're going to need it, to prevent a longer term issue of disrupting the anal sphincter, maybe having incontinence related to that, with the lesser evil of a short term increased pain and maybe a delay of return to intercourse for a few months, or pain with intercourse for a few months longer than if you'd never had an episiotomy or in general.
So was this like 30 years ago, 50 years ago, 100 years ago? Because I'm just picturing like women walking around pooping all over the place, flatulence all day, every day. Like, are we talking about my mom, my grandma, my great grandma? Like, when did this happen?
Yeah, so one, episiotomy, I think, was first coming into use, first being like experimented on, as far as what I could find available, around 1700. And that was in Europe. And so, what we do in the United States might have a different kind of time period, a slight different time period. Um, and also our population is different, so Europe is more homogeneously European, versus in the United States, we had a mix of free but non-voting, non-autonomous white women, and then non-free, non-autonomous Black women. So there's been a different trend and history to obstetrics in the United States as a white male industry compared to obstetrics in Europe. There's some overlap between what we do, and maybe they were doing medial laterals because they listened to the complaints and recognized, oh, you can't do this midline. It's, creating issues, versus in the United States, we were doing midline episiotomies for a while. So I would say that our
Wow.
grandmothers are probably in the routine episiotomy group. If they had vaginal deliveries, they were probably in the routine episiotomy group. And then maybe in our mothers, and it's not unusual for them to have some level of incontinence, some type of incontinence. But childbirth also is associated with continence, but usually more urinary, more rather than poop. Poop
Mhm.
incontinence generally is going to suggest that you had some involvement of your anal sphincter in during your childbirth that was disrupted, or you had like forceps, which and they can go hand in hand. And then our mom's generation was probably still getting episiotomies, depending on if they needed, if they had like a forcep delivery or something like that. Because even in my mom's generation, I think they were still using twilight, a fair amount, where it was very easy to just kind of put women somewhat to sleep and then do everything yourself, and eliminate that component of like interacting, with her in the pushing efforts. Now, for my generation, I'm 41. So for my generation, now we're getting into the realm of some of the younger obstetricians are recognizing and reading some of the information and are doing, if we need it, episiotomies. So I didn't have an episiotomy in my childbirth. My OBGYN was, more or less in my generation. We're probably not dramatically different in age, not more than like maybe 10 years. So, I mean, we could have people currently at the dinner table that have experienced significant differences in the use of episiotomy, depending on, if your grandma's still coming to dinner with you, or your great grandma. Yeah.
It makes me excited to see that we are moving forward, but it also is kind of a little icky reminder of how slow things move forward. But nonetheless, I'm glad that we're moving away from that routine episiotomy. And I wonder if the European medical community moved to that bilateral because they saw naturally that's where kind of the body would tear instead of directly up and down. What do you see in terms of like what you see in tearing? And also, isn't it true that tearing naturally can sometimes heal better than an episiotomy?
So I'm not sure how it heals. I think most of the time when you tear naturally, you don't tear into your anal sphincter. And so if your tears are going to be limited mostly to the vagina, whether it's a superficial or even what we call a first or second degrees, where we get past the superficial layer into some of the underlying muscle, but still within the vagina, most of that is going to heal really well. And people are going to have transient discomfort while it's swollen and healing, but long term, they're probably not going to have significant bothersome experience from it. So I think for the people that are going to potentially be at the greatest opportunity for long-term experience where it continues to linger, some effect of it are going to be those that it got to the anus in terms of its involvement. And that's going to be more common in the people that had episiotomy, especially a median episiotomy, which was what we were doing a lot of in the United States for a period. So, there's that. I mean, I think, yeah, it's just not, it's not as common. What we've realized when we look back, it's not as common for people to spontaneously tear all the way into the sphincter. And so many people will have superficial lacerations, whether in the labia, near where the urethra, the opening that allows us to urinate, inside the walls of the vagina, so on the, on the kind of the on the vulva and in the perineum. Many people will have very superficial lacerations that, may not even bleed, that those don't generally need sutures, that once we're not kind of spread open, with our legs open trying to deliver a baby and we do our daily life. A lot of times our daily life doesn't have our legs wide open, and some of that just doesn't have as much tension on it. It just comes back together on its own if it's not bleeding. Sometimes it doesn't even need to be stitched with anything. And then some of the, first or second degree lacerations that still stay in the vagina, they don't extend down into the area near the sphincter, they also may heal. The vagina is meant to be really flexible. It's a lot more forgiving if there are lacerations or if it's been really stretched, just comes back like an accordion, it relaxes and comes back together. So the vagina is very forgiving, can tolerate a lot in terms of transient things that happen, that it was like, oh, I'll fix this. Just give me a couple of weeks. Just let me rest for a little week. I'll get it together.
If you think about the vagina, she kind of is just this like self-sufficient thing. She's self-cleaning, she's self-healing. She was designed to expand and accommodate your baby's
Yeah.
like movement. So let her do her thing. So you had mentioned earlier forceps being used can sometimes be a situation that you used to see episiotomies be done. Is that still true today? Would something like shoulder dystocia be a reason? What are some other things that if we run into X scenario or Y situation, we may need to have a discussion about episiotomy?
Sure. So we're definitely in the phase um changing thought and changing the mindset about the need and the use for episiotomy. And like you said earlier, change can move slowly, and changing ideas it can move slowly. And so
It's hard.
the American College has, yeah, right. Well, American College has a bulletin. Let me see. It's not called episiotomy. I just want to remind myself. It's called, so the American College of Obstetricians and Gynecologists is an American collective of obstetricians that try to put information out there to make it easier to stay informed on topics. So they have a bunch of different things that they write, for those persons that are listening to this are like, what are you talking about? So it's like this group of esteemed obstetricians that are regularly studying different topics and going back and reviewing the information that we have about it, and then writing about it in a really comprehensive way, but something that's digestible, that, a few pages, not too long for you to read, to allow obstetricians, gynecologists, anybody who has access to what they publish to stay current on, okay, this is what we currently think is the best information about these topics. And so it's a great launching pad to kind of get a good review of what information's out there. And they put things out there every so often, and then they go back and review past works that they've published and see, okay, well, is this still really current? And we think that there are updates to this, and then they may update it, or they may say, no, this is the best information that we have so far. We're going to reaffirm it. We're going to keep it going. We're not going to change much. So they have a bulletin that's called Prevention and Management of Obstetric Lacerations at Vaginal Delivery. So it's not an episiotomy bulletin, but the topic of episiotomy is very heavily discussed in that practice bulletin. And so the reality that I've lived through in my relatively short career, I've been a physician since 2010. So it's still relatively short career, is that I have seen it change. The guidance has changed even in that short amount of time. There was a period of time when I was training where it was heavily encouraged that if you got into a shoulder dystocia, one of the first things that you should do is cut an episiotomy to assist you in your efforts at relieving the shoulder dystocia. And oftentimes at certain hospitals, they may even have checklists of how you managed a shoulder dystocia. And on there would be a check for, did you cut an episiotomy? So it was considered an integral part of managing shoulder dystocia. And I have not ever been very good at or had any significant experience with doing forceps. But I wouldn't be surprised if cutting an episiotomy was also an integral step that was just thought to be, step one, step two at placing forceps. And I've seen forceps placed, and I have often seen episiotomies cut before placing forceps. And it is the technique of applying forceps and getting that extra space before you even apply it. You have to do, essentially to put your hand in first, and then you guide the forceps along your hand. So now you've got both your hand, the baby's head, and this metal device that, even though it's like a spoon, so it's not very, very wide, but all of that is going in on one side to make sure that you can not bruise the baby, that you're getting all the way around essentially to the jaw area with your big spoon. And then you have to do that on the other side. Well, in order to fit your hand in somebody's vagina when they're in the stage of childbirth, that their baby's head is also in the vagina, they had to have significant flexibility. Maybe they are a mom that's had a previous birth and they might have more laxity to the vagina. Or sometimes you have to make a cut in order to widen the space of the vagina, right? That was the intention of the episiotomy in the first place, is to widen the functional space of the vagina by cutting that land bridge, the perineum, where it doesn't really widen the vagina, but it essentially is, creating more space in the general region. Now, the American College has looked back at all of what we thought were reasons to do it. And now they've taken the perspective, it's probably not beneficial to do it on a planned basis. And maybe it doesn't even need to be a part of shoulder dystocia management. Maybe it really doesn't have any absolute necessary role. And that's their current position.
Wow.
Maybe it's not actually necessary for anything. And so now we're in the realm of provider discretion. Now we're in the realm of changing the thought process about it and getting this information out there and saying, okay, well, the American College has looked at this and, they don't really think there's any situation where it's an absolute, yes, you need to do this. So that's the current takeaway point. I want to pause and say that again. The current takeaway point for all the moms out there, for any birth workers, young up and coming OBGYNs, anybody listening, the current takeaway point is there does not seem to be a role where it is absolutely recommended. That is the current position that the American College of Obstetricians and Gynecologists has taken on this. And now it's, okay, let's get into the realm of, we use it restrictively. And there's a kind of a different categories. It's routine use. We no longer think that routine use of episiotomy, meaning everybody gets it, is helpful for anything. We don't see any benefit to that. And we actually see increased potential for harm, increased potential for injury for the mom. And now we're at the level of, let's restrict its use, and we're going to say, for the most part, it's not absolutely necessary for shoulder dystocia. It's not absolutely necessary for operative delivery. Now you need to decide if you think you need that space. Can you get the space naturally, or do you need that space? It's not mandatory. It's not always needed in certain situations. Now, do you have the room or do you not? And then now it's restrictive is the recommendation. So we're at the phase where, one, we need obstetricians to know that this is the current impression and the current suggestion. And the American College is not the law. They put out suggestions, but oftentimes those suggestions are heavily backed by people that have had a lot of experience, that they've been looking at studies, they've been looking at information, they're trying to to evaluate the merits of what they've seen and see how strongly they can make suggestions about how to modernize obstetrics and to bring it, forward, and maybe leave some of the things of the past that should no longer have routine role in how we currently work as obstetricians. And so we need one for people to know this is the current thinking. And so not all new tricks get picked up easily, right? So we need people to know this is the current thinking, that it's not mandatory, that really you need to evaluate. Do you need the space? Do you not need the space? Can you get the space naturally without creating the tear? Do you need to cut in order to get that space? And then also they need to know, okay, they're not going to get criticized in certain situations that previously it was considered this is step one in order to
Mm.
do this intervention. If you have a shoulder dystocia, they're not going to get criticized for not cutting an episiotomy if they relieve it with other maneuvers. Then somebody isn't going to come back and say, well, how long did it take you? And you should have cut an episiotomy and get there faster. They need to know they're not going to be, criticized for not doing it. That's also an important aspect, is the negative impact, the negative feedback from not always the mothers that has the most impact on them, but sometimes it's their peers or the committees that, and like people that are evaluating them, that, okay, well, I think you were supposed to do this and you didn't do that. And, so there's that. And then it comes down to, in the moment, trying to do a quick assessment, because a lot of times these are time sensitive. Most of the time when you're in the current day of obstetrics, where many people are no longer doing routine episiotomy as part of their plan for every birthing mom. Now you're often doing it for emergency situations if you think you need it. And so, in an emergency situation, you don't have the luxury of a lot of time to consider something. So there's often a quick assessment that's being made to determine, do I have the space? Do I not have the space?
Hmm.
Is the area stretched enough on its own, or do I need to artificially create more space? And so I think that's, it's a multi-pronged challenge to kind of keep moving forward, is to change past thinking on it, to have providers feel like, okay, if I embrace this, I'm not going to get in trouble. Nobody's going to, like, sue me for using an old step, saying I should have done X, Y, and Z, because that was what people said in the past. And then the feasibility of doing something quickly when I think so. Hopefully that kind of addresses, I think, the current phase that we're in.
Yeah, absolutely. That was super helpful. So I guess I do have a question about just kind of what can we as patients expect from our providers. So I hear that there are two types of scenarios. One that we think we need an episiotomy and we maybe have a time for a conversation with our patients. And then one that is very emergent and we're doing this because we think right now we need to get this baby out. Could you talk could you tell us the language that you would use in both of these scenarios? So let's start with the non-emergent one. Maybe you've been pushing, you really think that if you could just give this mom a little bit extra space, you could help her be done with labor. What are you saying to this person?
I don't think that's, I don't, I feel like that's not what we should do. Um, Unless a mom is somehow communicating that that's what she wants.
Wow, yeah.
Because I think it's a short-term fix with the potential for longer term impact. And so,
Totally.
I don't think that, I think, as a person that believes in restrictive episiotomy, I don't think it's to shortcut your labor in pushing, as if the baby's doing fine.
Mhm.
I think
Mhm.
that I think the role for it is in the setting of, if especially regarding labor efforts and the heart rate pattern for the baby. There are times that we see that the pushing efforts are not being well tolerated by the baby.
Yeah.
And that where the heart rate pattern goes down pretty significantly and may linger during those pushing efforts and afterwards.
Scary
Um,
stuff.
right? And so you can hear it because at this
Yeah.
point in time, most of the time you're in the listening phase. You're not really looking at the heart rate tracing. You're listening to it, and so you see mom's heart rate. You see mom pushing. Oftentimes during the pushing, you may not be able to hear the heart rate very well. At this point, the baby's generally body's in the pelvis, the head is in the vagina, coming down through the vagina. It's sometimes challenging to even track the heart rate really well in that phase anyway, because the chest is now, probably coming into the vagina.
Mm.
And our external monitors are not always that good at picking up the heart rate when the baby is descending that low. And so then, the mom pushes, you don't hear the heart rate as well, or you hear that it goes down. And then she's, done pushing and is kind of catching her breath, waiting for the next contraction, and the heart rate is still down. And it's still down. And it's taking a while. And like, just as the heart rate's coming back up, maybe she's having another contraction. And you're like, ooh, okay, how much of this can this little person that doesn't have as much reserve, it's a little bit more fragile, how much can they tolerate? And you can hear patterns changing over time for the baby where it might take longer and longer for the heart rate to come back up. And so in that situation, depending on how long you've been at it, that's an opportunity to say, I think we're starting to get in the place where maybe it's not an emergency, but I want to prevent an emergency. And I'm hearing the change. It's taking longer and longer for the heart rate to come back up. If this goes on for a prolonged amount of time, it can depress, it can impact that how well your baby transitions from being inside to outside of the womb. It can potentially create a situation your baby needs additional help and may need some breathing, could have some injury from decreased oxygen. And so that could be a non-emergent role where you say, I'm seeing this pattern and I think your baby would benefit from shortening the last few minutes of this labor.
Mhm.
And what I appreciate in this situation, which I think needs to go hand in hand with that, is that your perineum is really tight. And I think that's why you haven't yet delivered your baby. It's not, it's this barrier that's holding things in. And I think if your perineum was opened up a little bit, that you would have your baby quicker, and then we wouldn't have this prolonged situation of these longer and longer periods of times with slower heart rate, slower recovery from not getting as much oxygen during delivery. And I think it's important to also add context to this. All muscle, when we contract that muscle, we cut off oxygen during a contraction. And then when we relax that muscle, then oxygen flows. And so the oxygen is coming to the baby through the placenta that's connected to the womb. And so when moms have contractions, these extremely strong muscle contractions, they cut off oxygen supply to the placenta during that period of time. And then when they relax, then the blood flows again, and then that's going to allow for continuing circulation of oxygen. And so there are a lot of different factors involved, and some babies are going to tolerate that on again, off again process better than others. Some babies may have some situations that are been going on in the womb that make them more sensitive to that part of labor, and that they're not going to tolerate that for as long as maybe another baby. So I think that that's a scenario where you're noticing that the heart rate pattern is staying down for an extended period after contraction's over. By the time mom's ready for the next contraction, the heart rate's barely coming back up, and then you're going to do it again. And that can be challenging
Yeah.
for holding its breath or not getting oxygen repeatedly, frequently. And you think the perineum is tight, and it is the last barrier to prevent expeditious delivery. Or you're in a shoulder dystocia and you can't fit your hand in. Most of the maneuvers for a shoulder dystocia are going to require that a provider put their hand in to then disimpact the shoulder from the maternal pelvic bones. And if you can't fit your hand in because there's not enough room between the vagina and the baby for you to put your provider hand in, that's another opportunity to widen the space, which is what the episiotomy is supposed to do. Same thing if now you are at the stage where the baby's coming down, maybe the heart rate pattern is changing and or your mom is exhausted. She feels like she can't push. Doctor, please help me. I just can't do this anymore. The heart rate's not good. Then a skilled provider who has forceps may say, okay, I know how to do my forceps, whip them out, And now, do I have enough room to apply this tool? I have to use my hand first in order to apply it safely to make sure I get past the ear, that it's not in this area, that I can make sure that it's coming around, the spoon is coming around here and here, so I can help to get this kid out. And so if you don't have enough room, okay, how do I get more room? That's it. That's the realm of the episiotomy. But I definitely think that unless a mom is really asking for a doctor, I just can't push anymore, I know my baby's fine, let's just hurry this thing up, I don't feel like we should offer that.
Mhm.
It's unfair to a mom, I think, in the delirium and the exhaustion and the emotional state of labor to say, you want me to just quicken this for you? And, and unless you're also going to say, and by the way, depending on how this works out, it could be more uncomfortable in terms of your recovery for a few more months than it would be if I just left it alone, or, if it extends and involves your anal sphincter, you could have need for long-term physical therapy, you could have incontinence. Like, if you're going to go through all of that, okay, sure. but it shouldn't just be, let me shorten this up, without explaining that almost any intervention we do in medicine comes with a potential inadvertent risk, where
Mhm.
there's some potential, there's a trade-off. For some potential benefit, there is the exposure of some new risk that may or may not have been there before.
Absolutely. Okay, and if it was an emergent situation and you didn't have time for this conversation, what does that look like?
Yeah. So you always have time for some version of a conversation, in my opinion. And I think that's what I put in the
I
comment.
could just hug you. I mean, I just love it. Ah.
You always have time. It doesn't have to be a lot of words. It doesn't have to be a lot of times. It could be something like, you by this point, you should already know what you're calling that person. Susie, I'm very concerned that the heart rate is going down over and over again. I don't think your baby's tolerating this well. I think the only thing that's standing in the way of you having your baby is your perineum. And I think if I cut this, we will avoid making things more dangerous for your baby based on the pattern that I'm seeing. Do you mind if I cut an episiotomy? Okay. Or I've seen some providers, I see that you're exhausted and your baby's heart rate is down. Do you mind if I help you? I can put forceps on, or, I can put something on to help you with your pushing, and we can help you bring your baby out earlier, because I see the heart rate's down, and I also see that you look exhausted. Do you want that additional help? Right. It doesn't have to be a lot of words to explain, what it is at that point in time. But I do think it's important to say, can I move forward with this?
Mhm.
Let me quickly present the scenario to you, and you tell me, can I make a cut? Can I apply this tool? This is why I think you or your baby would benefit. And most of the time, this is for the baby's benefit. It's usually not for the maternal benefit. I think I have concerns about what I'm seeing, or, I'm having a hard time getting your baby out, and I don't have enough space to do the things that I think need to be done. Do you mind if I make this cut? It's going to help me do what I need to do in order to safely try and get your baby out. And we need something to happen right now, because I'm concerned that we're in an emergency.
Mhm.
Doesn't take a lot. That's, a couple seconds. And
Yeah.
yeah, seconds matter, but it doesn't take, it's not going to belabor the process so dramatically that it's not worth it. And so I think that's a really important style practice takeaway that I'd like to communicate to any provider that's listening. Is very important to get buy-in at what you want to do. And if they say no, okay, then you got to deal with that no,
Yeah.
and do the best that you can do,
Yeah.
and it could end up being, maybe there's a spontaneous tear, and that, maybe they're going to be okay with that, right? So, but I do think there's always, I think that people appreciate that. When I've been in, really bad cases, I remember I was in a horrible shoulder dystocia. Not no, it wasn't a shoulder dystocia. I was in a horrible uterine rupture case, and there was a period of time where the husband was like, what is going on? And I stopped what I was doing. I was working with a trainee. I stopped what I was doing and walked around to the side of the bed. I said, let me tell you what's going on. Because you can't pretend that these aren't human beings involved in this. And it's really important to say, okay, this is what's going on. you know, it's really complicated situation. This is what we're doing. This is, your baby's going to need additional attention. The baby's got a whole team. We're going to be down here for a while with your wife, and this is what's going on. Okay.
Mhm.
And I'll come talk to you again when we're finished, but I want you to know
Yeah.
what's going on right now, because I can tell right now that you're like, my world just got blown up. Like, I don't, what is happening to all the people that I love? So I think it's important for us to remember that clinical medicine involves other human beings, that we are human beings, they are human beings. And that if we were in their shoes, we wouldn't want a lot of things just done to us without anybody trying to at least give us the ability to say, yes, I'm okay with that, or no, please do something else. Like, because they have to live with that. That
Yeah.
person who has that experience has to live with what comes with that experience. And so it's only fair to give them the autonomy to say, okay, I trust you, move forward, or please do something else. It's like, this is not at all what I want. And I was trying to think of, how do we prevent these situations? And there are a couple things that I was thinking about in preparation for our podcast that I thought, okay, how can I empower a listening mom in this situation? Because we are not the same person. I have an inside edge, right? So
Yeah.
I understand these things, and I'm going to pick a provider based on my knowledge of them. And maybe I've worked with them, I've seen them, I've heard rumors. I'm going to have, insider access to different styles, and maybe be a little bit easier for me to say, okay, this is the kind of provider that I would align myself with as an OBGYN, picking another provider to be my birth attendant, my skilled provider. And so I thought, okay, well, how do we empower moms that are not on the inside of birth work, inside maternity care, for their own ability to speak for themselves and express what they want? And so, one, there is this concept called perineal massage. And so this is something you can do, your partner can help you with. They can do it on your behalf if you want them to start to try and stretch your perineum even before you get into labor. And actually, some investigation of this has shown that there are less tears if you do this on your own. So this is something that you can say, okay, let me discover my perineum and let me start to try to see if I can stretch that area ahead of time. I can take matters into my hands, and then maybe I won't even need an episiotomy, because maybe it won't be tight in labor, or it'll stretch, it'll give a little bit more easily. And so the concept, generally, from what I've seen, and I wouldn't be surprised if there's more than one way to do it, is that you create this stretching where you just reach up just a little bit with thumbs, and you're going to kind of press downward on the vagina towards your anus, so downwards towards where the poop is, and then kind of outward, kind of creating a U shape, out and down. And it's just stretching that area where the perineum is. And if I can come across like a great, reference, or I'll try and send you so that we can include that for the resource of the podcast. And then your partner can do it if you're like, oh my gosh, I would never touch myself like that. I have friends like that. They're like, oh my gosh, I could never do that. Then you just, if you're okay with your partner touching you, hopefully you and your partner are on good terms at that stage of your pregnancy. They have not made you so upset with the baby that you're carrying for them and all of what you're going through in pregnancy. Then they can put two thumbs in the vagina, and not, it doesn't have to go that far into the vagina. It could even just be, the length of the tip of your finger to your first knuckle. Nails that are short, not nails that are long, and just press and create a U shape. Press down, out and around, create a U shape, almost like the U for my alma mater. And so, and do that maybe once a day for a few minutes to just kind of stretch and kind of release any tightness in that muscle part of your perineum and the lower part of the vagina, and that can help. So that's something you can take into your own hands to decrease your risk of some lacerations, or even potentially needing an episiotomy. It just helps in labor.
When should you start that? When would somebody wanna start perineum massage in pregnancy?
Third trimester is what I've seen, and so I think probably the last few weeks, before your term, would be a good time to start. One recommendation I saw would be after you take a shower or a bath, when you've kind of warmed up, your body might be a little bit more relaxed. That's an opportunity to do it. You can be in a seated way or lying down, whatever is most comfortable for you at that stage. And just for a few minutes, once a night is something that I've seen as an opportunity. In labor, the provider could do, if you're okay with touching, could do warm compresses over the perineum. That also helps to kind of relax and allow for stretching of the perineum, and has been evaluated as a method to kind of cut down on the need for episiotomies or significant lacerations. And then doing the massage on your own is something you can do yourself. Then I think another takeaway that I would communicate, and I'd love to engage with you, HeHe, about this as a doula, because I am starting to question whether doulas, whether we really need doula care to start from the first trimester,
Mm,
especially in picking your provider,
mm,
and whether your birth plan really should start either before you are pregnant or very early on, and then making sure that you are aligning your prenatal care with somebody from the beginning, that you're thinking through pregnancy and childbirth and postpartum from the beginning, and then making sure that you're aligned with a provider. And I feel like the doula is like a great person to help you figure out what it is you're trying to experience during your pregnancy and your childbirth, and then helping you navigate with the personalities and style practice preferences and people that in the community, like who jives with that, who's going to fit that type of style that you're looking for. And so what I would like to communicate is that really, as moms, we should feel comfortable interviewing our provider to see if they're a good fit for us. And it does not have to be the first person you go to. And at some point, the providers do an interview of their clients.
mm-hmm.
They do them to get to know them, to assess the risks of involved, what they're going to need to do. But on some levels, there needs to be an interview on both sides where that mom says, okay, I have some questions I need to ask you about what you do and about your style, because I'm trying to make sure that I'm picking somebody that's best fit for my team. And so I really want to empower moms to know that that is okay. I had a sister-in-law that I was so just like, I loved her confidence. I loved her boss attitude at some point. And she went through like 3 or 4 prenatal practices before she finally, settled on the group
Nice.
that she thought was best for her. And, would just transfer her records, to the next group until she found the right fit. And I think so many moms, either they're in a maternity desert where they don't have a lot of options,
Yep.
or they just stick with somebody that they, the first available visit of whoever, they just think, okay, I have to stay with this person. And some people know that they don't like that provider. They get weird vibes from that provider. They don't feel comfortable, and then they just stay because
Mm,
they don't, either they don't know that they can move and take their business elsewhere, and it is your business, right? You're paying for it, or they think that it's going to be challenging to do, or there's so many things I think that might come up as, okay, I guess I should just stay here even though I don't like this person. I may not trust them, but what else am I going to do? So I do want you to know you can shop around. And I think, correct me if I'm wrong, Hebe, I think that a doula could help in that process of trying to evaluate the providers in your region and starting to think forward about not just my childbirth in the 3rd trimester when I create a birth plan, but think about my pregnancy experience, start to find a provider that would align with the childbirth experience that I think, I'd really like to have, and maybe I'd be most likely to have under their care. And then find them early on and get your prenatal care with that provider, create a connection or rapport with that provider. And so I think it's completely appropriate to ask questions and to take out time in a meet and greet and say, okay, I have a few questions to ask you. Do you practice routine episiotomies? What do they say? Now, one, they're probably going to be surprised that you have questions for them, but that's
yep.
okay. That is okay. It's your experience, it's your life. And if you have a provider that has too much ego to answer questions, that's a flag.
Mm,
That's a concern. You don't want to be with somebody that gets so flustered and feels like, I don't have to answer questions to you. Well, that's a flag. That's already somebody that I would, want in my childbirth experience.
Bingo.
So ask them, hey, do you do routine episiotomies? Talk about it up front. Do you do forceps? For me, I think somebody that does forceps is a person that has additional skill and sometimes goes hand in hand with some other skills that are almost dying out in obstetrics. So for
Mm,
me, that's important to me. Somebody that has these skills, whether or not I want them to use it. But if they have them, then that tells me that that provider has some additional resources that not all obstetricians and current obstetrics have. So to me, that's like, oh, right, it tells something about you. You still have some of these skills that are dying out. But ask them to the questions, up front that you may want to know. I think waiting until the third trimester is not as ideal as evaluating somebody early on to kind of get a sense as to what their provider style looks like, and then giving you the confidence that you should continue your prenatal care with that provider, or whether you should jump ship early on. Because there's, some of the things that I think bother people start happening early. And some of the language and the coercion and the doubt, the seeds of doubt and fear, sometimes they happen early, and sometimes they don't need to happen at all. And it's really based on that provider and their skepticism and their own fear and what their ability to predict stuff, which is usually not going to be that great. Our ability to predict all kinds of things is usually not that good. So that's, if I could empower any mom listening, I would encourage you to connect with a doula early. Start thinking through the experience you want to have during your pregnancy, as well as your childbirth and postpartum. Create a list of questions of, these are the type of things that if somebody did this to me, I would be upset. If I knew this about them up front, I wouldn't stay in their care. What are those deal breakers for you? If I knew this was the type of provider you were going to be, I wouldn't give you my business. Okay, then let's put some of these questions together and ask people, and see how they respond. See if they have compassion, if they have grace, if they give you time, if you connect with them. Do you feel like you can trust them? Did they so I think that could be empowering to know you can move your business as long as you're not, that's extremely limited, but unfortunately that is the reality for some people.
yeah, I agree with everything that you just said, and I definitely agree that doulas can be helpful. So I actually have a list of 10 questions to ask when you're interviewing providers, and I'll link that in the show notes for you guys. But our clients are typically signed up with us by about 12 to 16 weeks pregnant. So our average client is with us for about 12 to 15 months. And I think the outcomes that we see with our clients are drastically different than with traditional doula care. And I think so much of it is because we have so much time with our clients and we actually get to, take advantage of those 8 to 10 to 12 minute prenatals. If you don't go in prepared with questions ready to answer them, it can feel like a whirlwind. Your doctor comes in, "Hi, how are you? Your weight looks good. Anything bothering you? Okay, great. Let's measure your baby. Okay, bye. See you next week. See you in 2 weeks. See you in a month." And you're like, what?" And so I agree with you wholeheartedly. I think a doula can be really beneficial in having that inside of the hospital insight to who the providers are, what their bedside manner is, what type of patient they are appropriate for. Because just because someone's not the right provider for you doesn't mean they're a bad doctor. It just means
Right.
you guys didn't jive. So there's a doctor out there for everybody. Yeah, I wholeheartedly agree with everything. Okay, I do have three final questions before we wrap up. So, one is, would you say that perineum massage is more important for someone who has had a previous episiotomy? And my thinking is there's going to be scar tissue there. So, would we want to use that perineum massage to kind of break that up to give that perineum the most elasticity possible during labor?
Sure. So I think some of the risk factors or some of the factors that seem to be associated with episiotomy are sometimes larger babies. Asian moms, first time moms.
Mhm.
So I would say that if you're in a first time mom, that this is the experiment. Your childbirth is, we never know what's going to happen. So I would say, if you're in any of those categories, people are starting to question whether your baby's a little bit larger than usual. Maybe there's going to be a increased potential for shoulder dystocia. If you're an Asian mom, I'm not really sure why Asian moms are in that group. If you are a first time, mom, this is going to be your first time going through childbirth, then I think that that would really be beneficial. I think if you have had a previous episiotomy or a laceration, that may also be beneficial to really just encourage elasticity rather than tearing, because sometimes the repeat tear rate can be significant if you've previously had either an episiotomy or laceration. Sometimes it just opens right back up again under tension. And so it could be helpful to create more elasticity if you've previously had a laceration, to hopefully prevent a significant tear or opening up again.
Yeah. Okay, and would there be situations where instead of or before cutting an episiotomy, you might suggest a position change, something that might, open up the pelvis a little bit more and or give that perineum a little bit more space in a, something other than lithotomy, I guess is what I'm thinking.
So for the hospital patient, a large majority of them, overwhelming majority, are going to have epidural during their labor.
Oh, okay.
I think that's a fair one. Most moms are going to birth in the hospital, and I think the ability to get an epidural is a high selling point for
Yeah.
people. That a lot of people are very concerned about how well they would tolerate labor pain, and so not all positions in an epidural anesthetized patient are going to be really feasible. That maybe somebody that was either doing something else for their pain management but not having an epidural, they're going to have a lot less restrictions on their ability
Mhm.
to maneuver. But if you are on your side, almost kind of like a fire hydrant, a dog fire hydrant pose, if you're on your side with one leg up, that seems to also have a lower risk of significant lacerations.
Nice.
And so this is interesting because this is also involves changing our thought process as OBGYNs in changing different positions, being able to kind of still visualize the architecture of the vagina and the perineum and the pelvis when we do a rotation, still to know kind of where things are with that rotational movement. And I think a lot of providers, they feel most confident in things that are familiar to them. And so this is a stretch for some people to be comfortable doing deliveries in a position that's not as common. But sometimes these positions are different positions, especially lithotomy is not the best position to open up the pelvis. And
Yeah.
so even a little bit of a rotation onto one side, with the other leg open, almost like I forget what that exercise was that had the actress with the, it had like the
It's
device where
like
you're
the
like,
clam. That's what I always think about, like the clam
right,
legs.
but something, and I had an epidural in labor, and I was knew that my pushing efforts were not doing anything, and my provider was so gracious but also like not giving me the real deal, and I'm not doing anything. I can feel that I'm not doing it. She's like, oh no. And so I really just wanted to change positions. I was uncomfortable in the position that I was in. And one of the nurses that was part of my labor team said, hey, well, why don't you lie on your side? And it was actually recommended to me because I was having breakthrough contraction pain that was very distracting to me. And it was hard to focus my pushing efforts because of this very focused pain that I just wanted to brace it. And so she said, why don't you lie on the side that's bothering you? And so I was on one side and pulling back on one leg, and somebody else was helping me hold that other leg, that, to create that leg up in the air, that dog kind of peeing on a fire hydrant concept. And and I pushed for less than 5 minutes and had my daughter in that position versus
Nice.
over 3 hours on my back doing nothing. And so it really, I felt empowered. It helped me manage the pain. It was just a game changer for me. And that position is one that has at least been evaluated and found to have less risk of significant tear. So I would encourage that. And I don't know if all the positions have been evaluated well. I think that's probably a more likely for OBGYNs to have evaluated, but I imagine that midwives who are dealing with moms that are choosing not to have epidurals are going to say, oh, there's all these positions that you could do to open up that space to stretch that area. And then, so I think that they have things to contribute as well in our understanding.
Okay, this wasn't part of my original 3, so now I still have 2 more, but you had mentioned that most people will have epidural. So can we say that an epidural, although it's still very rare, does increase your risk for a need for episiotomy or no?
So I'm not sure that I can make that connection,
Yeah.
but there are impacts from the epidural, especially depending on how an epidural is managed. So an epidural needs to be managed, and a savvy labor nurse will manage it. And so things that you need, it's very important for the epidural to be managed. And unfortunately, it's not often being managed by the people who are placing it. It's generally not being managed fully by the anesthesia providers, maybe because they're doing the next one, or they're on the go. So it's really a savvy labor nurse who's going to manage the epidural and make suggestions about how to manage it. And so the epidural its intent is to give you some numbing, essentially from the belly button area, maybe a little bit higher down through the pelvis. And so for the most part, that's where you're going to experience contractions. That's okay for you to have a numbing during the majority of your labor, but when you are in a pushing phase, you need to feel connected to your body. You need to be able to actively participate with what your body is trying to do and intensify that pushing effort. And at that phase, the epidural may work against you, because then you feel disconnected. You can't tell how much pressure you're generating. You may not be able to concentrate that pressure and say, okay, I want to contract in my pelvis and near my anus, or I want to put force in my vagina. And if you can't feel that anymore, then you feel disconnected. And so a savvy nurse will say, let's turn the epidural down so you can feel it, because you need to feel rooted to your body in pushing for the most part. And so then it's like, okay, there's maybe a little bit of pain or awareness of your body that you need to be connected to in order for your pushing efforts to really not be belabored, pun intended. And so there's some management that should happen with that. It really takes a savvy labor nurse to say, okay, there's some level of pain or discomfort that is helpful
Mm,
in this, in being able to have that birthing person be connected to their body. So sometimes being completely disconnected makes your pushing longer than it needs to, less effective, and that could contribute to next steps that could lead to, okay, a longer labor, and whether or not your baby tolerates longer pushing efforts.
yeah. It's
Yeah.
not a direct cause of an episiotomy, but you can see how the cascade can
Yes.
cause a compounding factor of, well, the epidural caused this caused this, and then this, maybe or maybe didn't cause this, but we did run into it, and it all compounded into, uh-oh, now we think we need an episiotomy. Okay,
Yeah.
cool. This has been super helpful. And my very last question is, if you've already had an episiotomy, what does it mean for future births? Are you guaranteed to have another episiotomy? Should you see how natural tearing works with your body? Do we have data around that?
Well, I don't know if you had an episiotomy once, if that is means that you have to have one again. And I think it's going to come down to your provider as well. Did you stay with the same provider who cut an episiotomy the first time? Did you go to someone else? Have they changed their position on it? Or maybe are the factors different in your second childbirth or your subsequent? Maybe that scenario where they thought they needed an episiotomy in the first pregnancy and childbirth does not completely present itself again. So you may not necessarily have an episiotomy again. You could have a spontaneous opening up, or what we call a laceration, where some layers may split under the pressure of the head coming down. So I think it's hard to really predict those numbers. I think there are a lot of factors that go into episiotomy rates, but I think maybe trying to take matters into your own hands and do some massage of the perineum could cut down on a need for episiotomy. We have some information that can cut down on rates of episiotomy or significant lacerations.
Nice. And I'm sure that patient preference comes into this, at some point. So if you have already had an episiotomy and you have very strong feelings about how your perineum is managed in your next birth, have this conversation with your provider. And like Dr. K said, if you have a provider who's not willing to have this conversation with you or just really feels very strongly in a different direction than you, don't be afraid to change a provider based on this one thing, especially if you had a lot of trouble with your episiotomy last time, or if it's just something you really strongly desired not to have. Don't be afraid to, chase that care that's going to be appropriate for you. Oh my goodness, you did exactly what I thought you would do, and you made a very scary topic not scary at all. And I feel like now people really can understand it is rare, but there is a place for it. And how do we come to that decision collaboratively with our provider to keep you and your baby the safest? And it's not just physical safety, it's emotional safety and
Yeah.
mental safety. And it's the whole experience of keeping you as an entire being safe. Right. Wow. This was empowering. I feel amazing. I hope our listeners do as well. Dr. K, thanks for being here with me today. I did want to leave you guys with one resource. If you don't know about leapfrog.org, it's a great website. Unfortunately, not all hospitals are on there, but the hospitals that did report, they did ask about episiotomy rates. And so for some hospitals, for some facilities, you can actually go and see the episiotomy rates. Another downside is not all hospitals have reported recently. So sometimes you go and their latest data is like from 2016. And you're like, well, this is almost 10 years old, so keep that in mind. But there are, some resources, albeit a little spotty, about episiotomy rates in your area. Dr. K, if people were interested in connecting with you or, they wanted to follow you on social media, you do a lot of talking about how to advocate for yourself, how to avoid unnecessary C-sections, how to actually have a really empowered birth experience from the OBGYN's perspective. And obviously, I really love that. How can people connect with you?
Oh, well, thank you. And I also just want to say thank you so much for having me on. Thank you for those who nominated me to be somebody that would be interviewed to speak and be featured. I am humbled. And if anybody wants to follow any of the content, Dr. K_pregnancy specialist on a few different social media mediums. I'm on Instagram, TikTok, and Facebook for the most part, a little bit on Threads, and possibly moving into the YouTube space, very slowly, but definitely Instagram and TikTok and Facebook. So I'd love to connect with you. There are ways to connect through most of those social media avenues. And I do Q&As every so often where I take questions and my stories to really try to just answer the questions that are on people's minds.
I love that. You're hanging out where all the cool kids are. All right, you guys. Thank you so much for being here with Dr. K and I today. It was so much fun. I know this is a topic where when you first hit play, you were like, oh shit, what are we going to talk about? And I hope that you're leaving feeling really informed. I hope you understand what an episiotomy is and why we might need them. And then I hope truly that you feel empowered and confident to have this discussion with your provider. And hopefully, if you don't get the response that you need, you have the confidence and the little nudge from Dr. K and I that it is okay to go out and seek better care because, my friend, you are worth it. Go find that care that makes you feel jazzed up. You leave their office and you're like, hell yeah, I cannot wait to have my baby. I trust this person. I feel safe. I know that they care about me and they truly want what is best for me and my baby, regardless of their own beliefs or their own typical common practice. This is collaborative care between you and your provider. And we really want to see that play out. All right, you guys. Happy hump day. Thanks for being here. And I will see you again next week. If you're listening on the podcast, head over to YouTube and vice versa. If you're watching us on YouTube, hello, go ahead to the podcast and give it a listen. Bye, you guys. Thanks for joining us. I'll see you next time on the Birth Lounge podcast. Until then, head over to Instagram and find us at Tranquility by HeHe and give us a follow. You can also check us out at thebirthlounge.com.